All right, we're going to go ahead and get started, and welcome, Jules, for joining us. Actually, I'm going to turn this right over to Nikki. As I shared with you, she's a practitioner. That's how I knew her. And she's done the work as a practitioner and now is working as a researcher and teaching teachers. So, Nikki, I'm going to turn it over to you. So thank you so much for everybody joining and being patient with us. Come back next Tuesday. I will run much smoother. Thank you.
All right, so tonight we're going to basically talk about the law and what the law actually says about mental and behavioral health in IEPs and a little bit about evaluation. Next week, I'm going to talk a little bit more about how it might look. So present some models of how school-based mental health kind of looks and where kids with disabilities kind of fit in there. So we'll get to that next week. So if you have questions on those kinds of things, try to hold them off to next week. And if you can't be here next week, I'm going to give you my contact information. And so feel free to shoot me an email too. All right, so we're going to kind of rush through this a little bit because I want to make sure we have time for your questions. That's important to me. And I will share these slides with Deb and she can send those out as well to people who want them, or you can email me and ask me as well. So we're going to start off with just a few pieces of information from IDEA, the definitions of some of the mental and behavioral health disabilities. So IDEA defines emotional disturbance. We often say emotional behavior disorder, but actually in the law, it is emotional disturbance still. That hasn't changed since the very beginning of the law. And you can see some of the definitional pieces here. I'm not going to read this, but I want to point out some pieces, how Iowa is just a little bit different than other states across the nation. That's because we are a non-categorical state, which started, I believe, in 1994 when the actual state law was changed. And so this is how IDEA defines emotional disturbance. And you'll note that there are 5 little specific definitions under there, A, B, C, D, and E. And one of them, the first one says an inability to learn that can't be explained by other things. So we have to rule out specific learning disability, autism, and some of those other things that IDEA defines specifically. Next is an inability to maintain or build satisfactory interpersonal relationships. So you can kind of think about this as our social skills pieces that we often think about, and inappropriate types of behavior or feelings under normal circumstances. So inappropriate types of behavior or feelings. So I think about this as our pretty typical, kid who's struggling with behavior and, maybe some anger control, emotional control kinds of things. And then we have a couple of pieces that are more mental health oriented. One, pervasive mood of unhappiness or depression. So it's mentioned right there in the law, depression is. And then E is a tendency to develop physical symptoms or fears associated with personal or school problems. And so that, look and sounds like anxiety. And so we see depression and anxiety, which are often, some of the more common mental health conditions that we talk about, directly within the definition in the IDEA. We also see at the bottom, emotional disturbance includes schizophrenia. And then there's this piece that gets all kinds of discussion in the literature and in practice in other states. And it says the term doesn't apply to children who are socially maladjusted. What does that mean? And that's a big discussion. So there is a lot of controversy surrounding that definition. There's the social maladjustment piece. There's really no clear definition in the law. And really it's counter to B. And if you look back, and B is an inability to maintain satisfactory interpersonal relationships. Yet social maladjustment seems like it would be a problem with social relationships. So that runs counter to that. there's an unclear connection to mental health diagnoses, even though depression is in there and some description of anxiety is in there. There's not a lot of connection to some of those things that are in that we would talk about in the world of clinical psychology or counseling psychology or other types of community-based settings. And then finally, there's a lack of explicit connections to cultural considerations. So what does it mean if a student comes from a family or a culture where this type of behavior or social interaction is typical of their culture, and it doesn't really talk about in there. So back in the 90s, and the citations for some of this stuff are in the notes part of these slides. So if you want them, I can certainly give them to you. So back in the 90s, as this was, really being talked about, the controversy was coming to a head. There was this big meeting where they talked about a new definition, and they wanted this to be part of the reauthorization in 1997, and it never made it into the reauthorization. But I want to point out some new things with this proposed definition that will probably, when we go up for reauthorization again, will be again discussed. So now we see the term, behavioral and emotional responses in school programs, different from appropriate age, cultural or ethnic norms. There's the cultural piece. That the responses adversely affect educational performance, including academic, social, vocational, or personal skills. So this isn't just about, kids are not, their behavior is affecting their academics, but behavior is also affecting their social relationships, how they're working on their employability skills and personal skills. And then it is consistently exhibited across two settings, one which is school related, and then they put in this RTI piece, unresponsive to direct intervention applied in general education. And then we move down to the second paragraph. The term includes schizophrenic disorder, affective disorders, anxiety disorders, or other sustained disorders of conduct or adjustment. And so then they're making that explicit connection to some of the mental health diagnoses that we do talk about in other areas and other settings. So this is not part of the law at this point, but this is something to kind of think about as we think about what are the disabilities that special education allows for lack of a better term. What are some of the disabilities that we can get services for in schools? And so this has been a real big part of the special education emotional behavior disorder literature, is talking about this definition and how we can improve it. Then we also have in IDEA the category of other health impairment. And I just wanted to point out one little piece of this. It's heightened alertness to environmental stimuli that results in limited alertness with respect to the educational environment. And then you can see down below, it shows attention deficit disorder or attention deficit hyperactivity disorder, along with some other things. And so this is the category under which kids who have attention difficulties like ADHD are placed when an educational evaluation is being done. So what do we do in Iowa? We have a non-categorical system in Iowa, which changes things. We don't use the category of emotional disturbance or other health impairment. Instead, we have a behavior disability or adaptive behavior disability. And this is because when we changed over to a non-categorical system, we really wanted to focus on the instructional need piece. Like, how can we really change and help and support students with some of these disabilities? And so the focus is then on the manifestations, the outward manifestations of those disabilities being behavior, adaptive behavior. And so we have this little bit of a different situation going on when families, when your students are evaluated for special education, they're not evaluated under the ED category or under OHI. They're instead evaluated under these different domains. Academic is a domain, health is a domain, and then we have these behavior and adaptive behavior domains. And so it looks a little bit different. And that's why I like to point out what the actual IDEA says and what we do here in Iowa, because it is quite different. But in Iowa, we still have to follow the IDEA. So we are doing it a little bit differently, but we are still, adhering to, if students have an emotional disturbance or another health impairment, that they are eligible for special education. We just sort of put them under the big category of eligible individual, and then talk about these different instructional need domains. So with that, when it comes to mental health, because our procedures manual defines behavior and adaptive behavior, it's like, where does mental health come into play? And that's even a question, even with states that do the categorical way of determining disability. Even under emotional disturbance, it's like, where do some of these, mental health conditions fit, and how do we work on that with some of our students through their IEP? So we put together some frequently asked questions. So Dr. Etchite and I have done this presentation across, in different parts of the state for the last 4 years or so. And so some of these are the questions that we came up with, and some of and then to answer these questions with some of the law that comes from either the IDEA or our state special education code. And the first question that we came up with that we are frequently asked is, what are mental health services and how do they differ from behavioral services? So mental and behavioral health services, we often kind of lump them together because it is somewhat difficult to piece them apart, but I'll talk about that a little bit. It's not a clear cut line, even for practitioners who've been working for years and years. It sometimes is a very mixed situation. So Platts and Lasser, who have written a book on school-based counseling, define mental and behavioral health services as a set of interventions designed to promote the social, emotional, and behavioral well-being of children and adolescents, and they must have these defined goals and objectives. And so that's still pretty broad and doesn't really get to, some of the details. So unpacking this a little further to really kind of drill down into what are mental health services, I use some of the literature to kind of come up with these ideas. And so think about social, emotional, or behavioral supports in which a trained mental health provider provides either direct services or indirect services. Mental health services don't have to be necessarily a school psychologist or a school social worker or a community-based provider coming and providing direct services to students. It can be that person is supporting the student through collaboration and consultation with special education teachers, general education teachers, and other professionals. So we have direct services or indirect services. They're not services provided by special ed teachers only without the collaboration and coaching of a mental health provider, because this would fall under specially designed instruction. And the literature talks about how teachers, don't really feel well trained in mental health. And so they need that collaboration and coaching from a mental health provider. Mental health services do not solely focus on the function of behavior, but also, not instead of, but also on behavioral symptoms of those mental health diagnoses, such as anxiety and depression, and can include a range of cognitive behavioral interventions aimed at increasing cognitive behavioral skills and decreasing symptoms of mental health difficulties. And so this is where things get a little muddy, right? There isn't this clear-cut difference between solely behavioral services and solely mental health services. So we have to think about this as a mental and behavioral health package. The next question that often comes up is, are mental health services allowed under IDEA? And the answer is yes. So under the IDEA, we have different types of services that can be put on an IEP. One is specially designed instruction. One is supplementary aids and services. Specially designed instruction is the instruction that's provided by a teacher. Supplementary aids and services are things like transportation and a paraprofessional service. And then we have related services. And this is where we're going to spend most of our time tonight talking about related services. And these services are listed in the IDEA as related services. These are things such as speech therapy, occupational therapy, physical therapy, things like that. So we have these related services. And Iowa rules also list, just like in the IDEA, the related services. And since we're talking about mental health and behavioral health, I want to point out a few other related services that don't get talked about as much. And even the literature across the United States talks about how oftentimes these are missing in IEPs, that maybe the student would need these related services, but for whatever reason, they're not in there. And I'll show you a couple pieces of case law, and Dr. Etchite will definitely talk case law with you in her presentations. So related services, we have counseling services, and those are defined here. And you'll notice that this definition of counseling services is very vague. It's just services provided by qualified people. We have psychological services, and they're defined here. And then we have social work services, and then they're, even more specifically defined. And you'll see that under social work services, we have group and individual counseling with the child and the family, among other things. So the IDEA does say, here are some services you can put on the IEP, and they act in the same way that speech services, occupational therapy services work. So let's dig into that even more. So questions 2 and 3 usually then come up to say, under what conditions must mental health services be provided? And how is a child's need for school psychological counseling, school social work services established? Those two things kind of go together. What are the conditions, and how are those conditions established? So IDEA requires that these related services must be provided if it is necessary to assist a child with a disability to benefit from special education. That is the language of FAPE, right? Free and appropriate public education. If the child requires services to access their free and appropriate public education, then we have to consider those services as part of the individual education plan or IEP. So how do we determine that? Well, evaluation is necessary. And Dr. Etchite, myself, and a student of mine wrote a paper that was published recently in Exceptionality that talked about this process of evaluation and what we really kind of found as we were doing our research is that the definitions of ED and OHI, so emotional disturbance and other health impairment, under the IDEA do not require a step-by-step evaluation process that directly links to mental health status. And the reason this is important is if you look at and read the law under specific learning disability, there are all kinds of procedural types of things that the law talks about. We now can do response to intervention ways of determining specific learning disability. We can do other types and ways, so discrepancy model ways of determining if a child has a specific learning disability. But the ED and OHI definitions don't really talk about how to evaluate and determine if a child has those two disabilities. So this makes things a little bit unclear out in the world of evaluation. And we've had to use our research over the years and best practices in school psychological services and assessment and measurement to determine what those best practices are. And then the other thing is that we often have an FBA as part of that evaluation. But one thing we were, learning as we were digging into the IDEA is that FBA, functional behavior assessment, is only required as part of a manifestation determination within the IDEA. So, and that didn't get put into the IDEA until the second or third reauthorization of the law. And So what kind of happened when that was reauthorized and added is that everybody started, if you go back and read the historical literature, everybody started talking, the professionals and the scholars started talking about, well, what is this going to do? What it's going to do is likely cause people to do FBA as part of every single ED evaluation, because they will want to make sure that that has been done before any manifestation determination is ever needed. And that is pretty much what happened. And so it's interesting to go back and really understand some of the iterations of the IDEA, the conversations that occurred in the scholarly literature, and then how that played out in practice. So as Dr. Etchite and I were writing this manuscript and studying all of these pieces of the IDEA, what we did was looked at best practices, looked at the IDEA, and proposed a model for doing evaluation. And this is the model that we came up with. And again, this is in our article that was published in Exceptionality in 2020. And what we basically said is, for every single assessment around behavior types of things, we want to do an FBA. It gives us great information. It provides us with that, sort of piece in the IDEA. If there was going to be a manifestation, we would have that FBA already done. There's a lot of great research around the information that is gotten from an FBA and how we can use that to develop really well-matched interventions. Ton of research on that, and it's out there and it's great. And so we definitely want to do an FBA. But we also want to think about how might we need to supplement that FBA with some other mental health types of assessment. And so we propose that if there was no clear function, or if there is suspected mental health involvement because of an outside evaluation, or parents just suspect there's anxiety or depression happening, that we would then do a mental health assessment as well. And that these two kind of pieces of assessment would then lead us to making some identification about what's going on with that student. What are the strengths? What are the difficulties of that student? And how can we then move forward and develop well-matched interventions? And so when we think about the types of disabilities, the types of instructional needs that come out of these types of assessment, we might have kids who just have a function-based behavior issue going on, and we use then function-based intervention plans to support that student. We might have a student who has 100%, a mental health oriented difficulty, and that's what we find. And so we might use cognitive behavioral therapy or other types of evidence-based interventions to support that mental health need. And a lot of times what we're going to have is, a combination of both those things. We have a mental health piece involvement, and we have some function-based thing happening where the child has learned that pieces are reinforced, behaviors are reinforced, even though those behaviors may be manifested from anxiety or depression or trauma or ADHD. And so then we would do some cognitive-based interventions along with maybe some cognitive behavioral therapy or other types of evidence-based therapies. And so this is kind of the model that we put together in that article. And that would then help us to have all of these great pieces of information to make the best match to instructional need, both the function side and the mental health side, because there's great research in that behavioral piece and applied behavior analysis, functional behavior assessment and analysis. There's great information that can be learned from those pieces. And there's great information that can be learned from mental health assessments that we also use structured interviews. There's rating scales and things like that. And of course, observation, anytime we can do direct observation for long periods of time, that helps us as well to understand the environment and how that student is interacting with their environment. So this is just a model for assessment and how we get to that intervention piece, how we determine, does a child need mental health services within their IEP? So then IDEA goes along to require that special education and related services are provided to a child with a disability, that they're actually specified in the IEP. And we all know that if we've been working in special education, that things that the child needs, we need to write in the IEP. I was just talking with a school psychologist and some teachers and a parent, and we were talking about all the wonderful things that this general education teacher was doing for this student with a disability. And a lot of those things weren't written into the IEP. And I'm like, write them in. You know, so many times we do our best for kids. Teachers do their best for kids, and we don't write them down because those are just things that I do, right? I'm just doing what's best for kids, but we need to write them down. And so we use that evaluation data, using that model perhaps that I just presented, to develop programming that meets the student needs. And again, like I said, next week, I'm going to talk more about who might provide the programming, some models for that, and how we can support all children. And so we're going to save that little piece for next week. But those kinds of services then would get put onto the IEP. So then when we talk about services, question 4 automatically comes up. And the question is, what costs does the school district assume, if any, when students are served in private schools, residential placements, psychiatric hospitals, or other community-based services? So that could be a mental health counselor or other kinds of therapies that are done outside of the school building or in conjunction with the school building. And the answer is it depends, of course. So if a student is placed in a hospital or any one of these programs for medical reasons, then the school district is not financially responsible. So the IDEA, I don't know if it makes it clear, but it does specify that any medical needs are to be not paid for through the school district that is providing the educational programming. There's also been a lot of case law on that as well. And so I'm sure that's been dug into, but if it's medically necessary, then it's not a financial responsibility of the district. If a student is placed in the hospital or other programs for educational reasons, behavior at school, those kinds of things, the school district may be responsible for the cost of the placement. Some of that depends on what the IEP team says is necessary for that student to access FAPE. If the student requires these programs to access psychological or counseling services to benefit from their special education program, that's the FAPE language, then the district has to assume the cost of those placements. So if this basically, to boil this all down, if the IEP team sits around the table or around their Zoom meeting, right, these days, and they together look at all of the assessment data, look at all of the things that are going on in school, and they determine that in order for that student to access their free and appropriate public education, they need counseling services. They need one of these more, restrictive environments. Then the district does have to assume the cost of such placements. So that brings a lot of pressure onto the IEP team. But again, we know that that includes the family, the LEA rep, who's often the principals and other people who have knowledge of the resources of the district. It also, those two have to be there. Also includes a special ed teacher, usually, gen ed teacher. And then oftentimes it's somebody who can interpret the data, like a school psychologist, school social worker, those kind of people. And so that team, and then other members that the family invites, the school invites to be part of that team. And so then it really goes to that team to make the best decisions for kids. And that is not always simple, right? Many of you who are out there who have been in IEP team meetings know that some of these things can be really difficult. And that's absolutely the case. So there's often no clear-cut determination on this, and this can be a hard decision. And of course, if the student is benefiting from the school district program, then nothing extra is needed. So they're doing okay. So it really does depend, but that IEP team really helps to make those decisions. If it's medical, that's not a school thing. And then it comes down to that IEP team making determinations about what that student needs to access their FAPE. And the other piece of law that sort of comes in here, which I don't have up here, is the Andrew F. case that was decided by the Supreme Court a few years ago. And what happened with Andrew F. is that the Supreme Court said no longer can school districts just say, I'm going to provide the most minimal services possible to students with disabilities. Now the language is still tough to determine exactly, but now students must have services that create situations where they are making progress towards their goals. And so if a student is not making progress towards their goals, then it comes back to the IEP team to change services in order to support that student and get them making progress on their goals. So that Andrew F. case really changed the way we think about what I'd always learned in graduate school and beyond is Chevy versus Cadillac services, that we only needed to provide, the basics and the school district didn't have to provide, these Cadillac services, the most optimal, the best services. We just had to provide the minimal services, or de minimis is what the Rowley law used to say. And now we've kind of upped the ante a little bit with that Supreme Court decision. And now maybe we're giving, Toyota services versus Cadillac services or something like that. I'm not sure what the language is around that these days, but we've moved up from Chevy. So a couple of case laws just to kind of illustrate this point. And like I said, Dr. Etchite is the ultimate expert in some of the case law, and she will be providing you some of that in her webinars. But a couple of recent cases that I wanted to share: the McMinnville School District, which is in Oregon. This was just a couple years ago. A 13-year-old student with conduct disorder who was eligible for special ed under the OHI category. Again, categories in other states. Iowa's the only non-categorical state in the nation. So we're cool and unique in that way. The IEP that had been written for this student had 30 minutes per week for behavior, 170 minutes for study skills, and then counseling 2 times a month. But the student wasn't making progress. And so the judge ruled for the parents. The judge said that the IEP denied FAPE and that student's family was given compensatory education, which ended up being about 14 hours of counseling. And then Manhattan Beach, which is in California, this is in 2018, we had a 13-year-old student again with specific learning disability, ADHD, and anxiety. The student was having increasing anxiety, panic attacks at school. She was determined eligible for special education, but there was no counseling listed in the IEP. She continued to struggle. She had a hospitalization due to panic attacks. And so the parents went to due process with the district, and the judge ruled for the parents, again saying that the district denied FAPE and provided tuition reimbursement to that family to the tune of $45,000 for private therapy. So what we see in these cases, and there are other cases these are some recent ones, and again, like I said, Dr. Etchite will be showing you some other ones, is that the law and the case law are supporting this idea of related services and providing counseling and mental and behavioral health services for students who are struggling with mental health types of things like conduct disorder, ADHD, anxiety. So I know that Ask Resources and Deb talked about how they often have these essential questions to help families and IEP team members really come together and start asking essential questions and guiding some of those conversations within IEP team meetings. And so I wanted to provide you with 2 essential questions out of this particular content that both educators and families can be asking as they navigate this world of mental and behavioral health assessment and services. And one would be, how do we consider my child or the student's mental health as part of the evaluation process and as we determine those IEP services? And then 2, does the student need mental health related services like counseling or social work services, psychological services, in order to access their free and appropriate public education? And these are not easy questions. They are not. And assessment data is going to be key in helping the IEP team really make well-informed and the best decisions for students who are struggling with behavioral mental health kinds of things. So that's the webinar, but I have a little plug here, and then we'll ask and answer questions. So I am working on some research right now, and I would like to invite all parents of students who have behavioral or adaptive behavioral IEP goals to participate in this study. And what I'm doing is investigating how mental health services are written into IEPs and behavior plans. So if you have a child who is being served under those domains of behavior or adaptive behavior, and you are interested in participating in some academic research, you can use the link below to read the consent form that goes over what exactly needs to happen as a participant of the research and indicate your interest. And basically, participation is just sharing a copy of your child's IEP with me, and that's it. So if you have any questions, you can contact me. There's my email. If you have questions about this research that I'm doing, if you have questions about any of the content that I presented, I'm happy to answer emails and support families and professionals across the state. I know this is not easy stuff. Behavior is hard. It is emotional, right? And so we all need to work together to support kids. Okay, thank you all. And I think we'll turn it over to any questions that have come up on the chat.
Well, thank you, Nikki. Somebody did ask when we would get this posted. It'll be relatively, as quick as we can get it turned around. So we do have somebody that does help us with that. So we will get that uploaded as soon as he gets it completed and gets it YouTube ready. So all 4 webinars actually will get posted along with the other ones that we already have there that you might find useful on different kinds of topics. I didn't see, hang on a minute. You have a question from Alicia. Can the IEP team determine that a residential setting or a PMIC placement, or really any other unique placement, is needed for educational reasons to allow the student to receive pay and still require the family to be financially responsible? It is my experience that is often the family who is financially responsible for such answers or placement,
Yes.
sorry.
Great question. And I don't exactly know the answer, because I know oftentimes in those more expensive placements like PMIC units and other private placements that, there's a lot of negotiating around all of that. So I think that would need to be for a lawyer who has way more expertise in the nitty gritty of the law than I would have at this point. So I don't want to answer that question because I'm not totally sure and I don't want to give wrong advice. So those kinds of really expensive, tough placements, I think I've seen, parents definitely being part of that. I've seen law enforcement kind of make some determinations about some of those placements so that, the state takes over the payment of those kinds of things. So I think, the best thing to advise is to, really kind of dig into that with an actual lawyer, or maybe ask Sue and see if she knows.
All right.
Sorry, I can't answer that better.
Got a couple more. Another one, what if it is deemed for both medical and educational reasons?
Yep, that one's going to be difficult because of the medical piece. The IDEA, again, I said it's not, totally clear, but it specifies that medical things are not for educational reasons. And I think you're getting to a place where it's getting, into the case law and what case law supports. Yes, the school district needs to pay for that versus, it's a medical reason and family insurance needs to pay for that. And again, I'm going to have to turn those really difficult questions over to actual law experts. I know only so much about the pieces of law when we get into some of those really tough places.
All right, I've got another question for you. Can you share some ideas of goal areas to address mental health needs that special education roster teacher is the author of? I hear that a MH prof is responsible to provide direct service or consult on the service. As a result, is there a conversation about how to increase these professionals, individuals in our districts and buildings?
So I hear two different questions there. What are some goal areas? And actually, Dr. Etchite is going to address this specifically, I believe, in her first presentation. So 2 weeks from now, we are writing a paper together that really lays out what an IEP would look like from the, RB page, which is the PLAF, the present levels of academic success, that piece. It's our B page, I believe. All through, so what that might look like and what's on that page, to what are some specific goals, to how do we progress monitor those goals, to what are some services, both specially designed instruction and related services, to how do we evaluate those things in terms of intervention integrity, all from assessment on down through that IEP. So she's really going to dig into that. And some of the goal areas that we sort of talked about can be, some of the things that we're pretty used to seeing. They can be behavioral manifestations of mental health stuff, like attendance, like not getting work done, like office referrals, which are not my favorite thing in the world to add to IEPs because they're teacher behavior and not student behavior, but they're accessible data, all the way to some goals around learning skills, coping skills. So maybe a goal around independently demonstrating behavioral or kind of breathing skills or other coping skills, utilizing a self timeout, those kinds of coping skills when stress or anxiety is heightened. So those are some of the kind of goals that can be done around mental health. And again, Sue's going to really dig into that. So you can look forward to that. And then the second question I heard was, is there capacity in our schools for this kind of work? And it's a great question. It's something that, there's no perfect answer to. We have people who are mental health providers who are working in school districts and with school districts across the state. And as we know, with all mental health within the state of Iowa and the United States as a whole, we have a shortage of mental health providers. Big time. That comes from my National Association of School Psychologists. That comes from the National Association for School Counselors. That is talked about, in terms of psychiatry. That is talked about in all areas of mental health, that there is a lack of mental health providers. And so capacity building is key, both in terms of finding ways to get more mental health providers in our schools, accessible to our students, but not only that, but also building capacity within the people who work within the school district. And I know several of you are from the Des Moines area, Please Pass the Love, which is an excellent nonprofit that is working on, really building capacity for teachers and educators on mental health kinds of things. And so we just have to continue this work. This is something that, in the past, I've been in this world. I've been a school psychologist for 13 years. And before that, I was doing my master's program in clinical psychology. And it just, mental health in schools wasn't a thing that was really talked about a ton. In the early 90s is when school mental health centers got federally funded. So there was one in Baltimore and one on the West Coast in Los Angeles. They still exist. They are awesome resources. And that work just, had to build and build momentum behind it. And certainly I think that momentum is here, and we really, the pandemic, that even made that even more clear that we really need to continue to build capacity, both within our community-based mental health world and also our school-based, and to connect those two as much as we can.
So we've got a couple more questions and we're getting close to the end. And Jules, I want to thank you greatly. She went beyond the call of duty to stay with us tonight, so I did not notice. So thank you very much. I'm gonna, one is, how is UNI working to improve capacity for improving mental health services in your pre-service training? Another is, and I'll let you kind of pick from these, Nikki. Can you speak to how collaboration between a school district and private mental health providers can begin? And maybe you can talk about some of these next week too. For example, how does a district work to have access to outside providers such as Orchard Place, LifeWorks, etc.? Is there funding for the outside of the district? And then we have somebody that has asked, in determining evaluation tools, are there examples of mental health assessments available to school districts? And I don't know if that's something you're going to touch on next week.
Yeah. Awesome questions. Collaboration between school districts and community-based mental health providers, we are going to talk about next week. I'm going to present 3 different models for school-based mental health integration with community-based mental health providers and other kinds of models for students accessing mental health care. So I will definitely address that in some detail next week. Evaluation tools, I think that's a whole nother thing. And what schools have access to is very different. There isn't like one, way to evaluate mental health. I mean, this is why quality providers, mental health providers, and that expertise is really needed. Because, as people go to graduate school and learn how to be a mental health counselor or a school psychologist or a social worker, we learn how to do those types of assessments. And so, there isn't one specific tool I can say that all schools have access to, because that's just kind of not how it works. And that's we can do a whole nother webinar on, sort of assessment and that kind of stuff, but that's a tough one to answer in a short amount of time. And then the UNI question in terms of teacher education, I love that you asked that question. I don't know if it was somebody who already knows something that I've been working on, and so they're just like, giving me a handoff here. But excitingly, I have been working with colleagues across the teacher education program at UNI. So our secondary ed, a few secondary ed folks, some elementary education folks, school psychology folks, and then also our folks from the Center for Violence Prevention. And together we created a social emotional learning certificate that is open, that will hopefully go through the curriculum process and be available to all teacher education students. This certificate, most of the classes are classes students already have access to. Some of them are ones that they are already required to take as part of their program. So we're trying not to add more credits for teacher education programs. And then they will take an SEL seminar with one of our colleagues in curriculum and instruction who's been teaching something like that. She's taught it once in an honors program, and it's a great course that really talks about social emotional learning, what it is, how do we, as teachers, what do we do? How do we bring this into our classrooms and things like that? And then they will also be part of and have to participate in several on-campus or off-campus workshops that would relate to social emotional learning and mental health. So that's very exciting. It is going through the curriculum process right now, and we hope that it will be open for students to register for that certificate starting in fall of 2022. Yes, the university process works slowly.
That's awesome.
But we are very excited about this, and we have heard nothing but really great feedback, because we know that this is something that in-service teachers are working on. We want to get our pre-service teachers well prepared for that work in the classroom. So we're very, very excited about that. Another piece that UNI is also doing is we are starting hopefully an annual, but definitely in April of 2022, April 15th, actually, if you want to jot that day down, we are planning. So myself and a special education colleague and another special school site colleague is working on developing a social emotional learning conference. It will be an all-day conference on April 15th in 2022. And we have several statewide people coming to talk about their work. And for example, Jeff Forsberg is coming to talk about social emotional learning in the classroom from both an administrator standpoint. Oh, there we go. Somebody's home. Sorry about that. We have some national people coming as well to talk about social emotional learning. So that is very exciting. So we are at UNI definitely diving into, building capacity within our educators across the state.
Well, I think, again, Jules, I thank you very much. She chose to stay on. I made a mistake, and so she stuck with us all night. So that I'm very grateful. Thank you. We're all giving you thank you very much. Thanks everybody for joining. Please fill out the feedback form and come back next week and the whole month. Just a wealth of information to share with all of you. And we look forward to hearing and seeing from you again. So have a good rest of your evening. And thanks, everybody.
Thanks, everyone.